Okay, folks, welcome back once again. Here we are in the course on bioethics, Masters in Cell Molecular Biology at St. Thomas University. One more light there. There we go. Okay, so moving forward, we're still in the section of end-of-life issues for, I think, a couple more lectures. So this one, we're going to be looking mostly at euthanasia and physician-assisted suicide. Technical distinction between the two, but the end result is basically the same. And then, of course, some alternatives to that in healthcare. Before proceeding, any questions or comments from anything previous? Nothing? Sorry? No, not from previous. Okay. Okay, so like I said, we're looking at euthanasia, PAS, and then what I'm calling the healthy alternatives to those, which would be either hospice or palliative care, the distinction between the two. Then terminal sedation, which is still controversial, depending on how it's applied, right? Returning to the big issue here of killing versus allowing to die. I keep emphasizing it because the distinction may be subtle but very real bioethically, whereas killing is not ethical, but allowing to die is definitely ethical. And once again, many people don't know how to make that distinction, so you are becoming masters, you are becoming experts, and therefore you can help other people make that distinction. And then I want to look at a couple of case studies in application of this. And I forgot to add on this list, also I want to review that document from the ANA, which is the American Nursing Association. All right, going forward then, a little bit of history. Originally, euthanasia is good death, or a true death, comes from the Greek euthanatos, and thanatos is a reference to death. The prefix eu typically means good or true. For example, eukaryotes. Eukaryotes, what does that mean? They have like true what? Karyo, what's karyon in Greek? The nucleus, the nucleus. Karyon. Eukaryotes, right? The karyon in Greek with a K is nucleus. It could be like a derivative meaning, but karyon is basically the nucleus or the core, and therefore true nucleus, true core, right? In contrast to the prokaryotes, which are the bacteria or archaea, that don't have a true nucleus. They may have a DNA concentration, but there's no nuclear membrane specifically. All right, so anyway, just for the point of view, euthanatos, that's where we get euthanasia, is a true or good death. In the original meaning of this goes back to classical Greece about 3 centuries before the time of Christ, so quite a while back. And then that term has evolved over the centuries. And then for a while, we were talking about positive euthanasia or active or passive euthanasia. Active would be actually the direct killing of someone, whereas passive euthanasia would be letting someone die, but by neglect, instead of providing care for a person who cannot feed themselves, but they are still very much alive and no one feeds them, okay? So that would be a type of passive euthanasia. Today, those terms are historical, they're no longer being used. And so basically, euthanasia is understood as causing death, and typically is to alleviate pain or suffering. So the intention, at least, is still a good intention, is rescuing the original meaning of euthanasia, is that the intention is to alleviate pain or suffering, all right? But the difficulty is that it's causing the death of the patient directly. So bottom line, instead of killing the pain, they're killing the patient who has the pain. There are a couple of ERDs that we're going to take a look at, but before going there, just looking at some definitions that are available for medicine, and then a broader definition just from Webster's dictionary. Medicine Net, for example, the practice of intentionally ending a life in order to relieve pain and suffering. So the relief of pain and suffering is the intention, right? So in principle, a good intention, but it's intentionally ending a life, right? In other words, it's not really allowing a person to die, but it's actually killing the person. For mercy killing is another euphemism that is used, okay? Or like in the area of pets, putting them to sleep, right? But it's a permanent sleep. All right. Medical dictionary, deliberate ending of a life of a person suffering from an incurable disease. So it is, again, deliberate ending of a life. It's not just allowing to die, but it's actually intervening actively. Including withholding extraordinary means or heroic measures. So here's where it gets ambiguous, because we know that extraordinary means or heroic measures, right, are not binding ethically. They are not, a person may want to do them, a patient, but they're not obligated morally to do them ethically. And therefore, the definition is a little ambiguous. It does pick up the traditional meaning of positive or negative euthanasia here, active or passive. But it says today, euthanasia is understood as active, in other words, causing the death of the patient, right? So what used to be known as passive euthanasia, allowing not providing life support, well, that is foregoing life support treatment. A more general definition, this is from Merriam-Webster, which is pretty much one of the most popular and used dictionaries throughout the world. The active practice of killing or permitting the death of hopelessly sick or injured individuals. So you see, it's a little ambiguous. Again, killing is a direct action, whereas permitting the death, well, the person may be dying, they may have terminal illness, all right, and systemic organ failure. So that one is permitting, allowing the person to die. See why it's ambiguous? But it is broader in a broader context. So any individual, including non-humans. So pets would also be included here. Right, and so they introduce again the concept of mercy or compassion. So in principle, that intention is a good intention. In other words, we're not supposed to be euthanizing healthy people, all right? However, I can tell you that in Europe, at least, this has gotten out of hand to the point that in some countries, like Belgium and other countries in continental Europe, even a healthy person just for old age may request euthanasia, and it's legal. And they're not really dying, they're just old, and like they say, they've had it with life, they don't feel useful. There's also a mentality that seeps in sometimes that they don't want to be a burden to other people, right? Maybe they're incontinent or something like that, but certainly incontinence is not a life-threatening illness. So that's why it's a very, very dangerous situation. This.
So the definition of euthanasia is not firmly developed yet?
As you can see, just from stuff that is online today, all right, it's a little ambiguous. They're not really making a distinction between killing or allowing to die. Most of these definitions do state that the patient is either in pain or suffering, but it may not be, it may be chronic, but not definitely dying, right?
Probably be the subcategorizations.
Yes, yes, exactly. And then when it gets into the legislature,
Necessary.
they try to legislate. But you'll see that when we look at PAS, that's where the jump has gone over. All right, we'll get there. I want to look a little bit at euthanasia from the principal perspective that I'm covering in this class. And so I'm using two ERDs, 60 and 61. You can see for the numbering that they are in the end of life section or part, all right? So first, the definition itself, euthanasia is an action or omission that of itself or by intention causes death in order to alleviate suffering. So it's, it's causing the death of the patient, all right? And it can be either an commission or an omission by denying a basic care. We'll look at care again and the four basic things that make up minimal care. Catholic healthcare institutions may never condone or participate in euthanasia or assisted suicide. So as far as this concept is concerned, the two in the end are the same, okay? Even though there is a technical and legal distinction whereby euthanasia is illegal in the United States, but assisted suicide is becoming legal in more and more states. All right, so dying patients who request euthanasia should receive loving care, psychological and spiritual support, and appropriate remedies for pain and other symptoms so that they can live with dignity until the time of natural death. So natural death, by natural death, we mean that at least one vital organ is dying irreversibly. Okay. Next one, patients should be kept as free of pain as possible. So this is emphasizing a little bit. It's expanding on this last sentence here, all right? But giving it an entire directive so that if it were just Directive 60, it may seem that, well, then we're not caring for these people who are dying. What do we do with a dying patient, all right? What's the alternative? Well, the alternative is to be kept as free of pain as possible so that they may die comfortably and with dignity and in the place where they wish to die. Since a person has the right to prepare for his or her death while fully conscious, he or she should not be deprived of consciousness without a compelling reason, right? So at some point, the side effect of analgesics or painkillers is that it will render the patient unconscious. However, that's not without its consequences and not without importance, because again, based on the belief that there is an afterlife, we should allow this patient to do a final preparation for that transition if they wish to do so, including speaking with a priest or counselor or in their own faith tradition, whatever that is. And if they're unconscious, then they cannot do that. Medicines capable of alleviating or suppressing pain may be given to a dying person, even if the therapy may indirectly shorten the person's life. Right? So this indirectly means that it's not the direct intention, even though we know the typical analgesic is going to be what? Morphine, right? Which is killing neurons. So you kill enough neurons, and the person is going to go unconscious, or at least start not really hallucinating, but they cannot think rationally. Yeah. Mm-hmm. So now the intent is not to hasten death. Again, a lot of emphasis on the intention, right? And that the action should follow the intention. Patients experiencing suffering that cannot be alleviated should be helped to appreciate the Christian understanding of redemptive suffering. It's another value also that, frankly, I think it's paramount, because at some point there is going to be a tolerance, an increasing tolerance to painkillers. It's part of the kind of reaction of the body to foreign object, meaning the analgesic. And so what happens is with increased tolerance, let's say to morphine, then a larger dosage has to be given. That's called titration, larger and larger. And therefore, there may be a point that they have, depending on how the painkiller is managed, that they get into what is known as intractable pain. Intractable pain is that no amount of analgesic is going to relieve that pain unless the dosage is so large that it really knocks the person out. They may not die outright, but it does render them unconscious. And then we don't really know, once they're unconscious, we don't really know if they're in pain or not. We have to kind of interpret signs from the face, grimacing or something like that, okay? But they certainly cannot verbalize it. Think of the Glasgow Coma Scale. All right. Also, I want to go back briefly here for, yes, the place where they die, because this is important vis-a-vis hospice/palliative care, all right? Because I was reading a while back that it's about 60% of people in the United States do not die at home any longer. They die in an institution. I don't know if, did I mention that here, because I'm having another course in end of life also. Sometimes I get the two lectures confused, but I had not mentioned that statistic. Okay, yeah, it's like 63, 64% of people in the United States are no longer dying at home. They're dying in an institution, typically a nursing home or hospital or a skilled facility, something like that, an ILF, but they're not dying at home. And so in principle, you know, that's really not the ideal. It's very short of the ideal because they're not necessarily surrounded by the loved ones, okay? And it will be more of a professional setting that is more standoffish, and therefore when that person needs most comfort and assurance and be surrounded by loved ones, they're not, okay? So that's important to keep in mind, that hospice allows for that in a healthy, ethically healthy way. All right, let's move then to, all right, a little bit more on the issue of pain and suffering. When we put it in this issue of context of faith, right, the belief of an afterlife, and particularly in the Judeo-Christian tradition, suffering and or pain also has value in and of itself, and it's called redemptive value. In other words, it has a value of purification, and we use analogies like, just like metal is purified with fire, right? That burns out the dross and pulls out, purifies the actual element. Similarly, by analogy, pain and suffering has the capacity to purify us spiritually, right? But it has to be put in the proper context. In other words, not that we seek pain or suffering in our life, we're not masochists either, but we live long enough and sooner or later some pain or suffering is going to come. For example, the death of our parents. I mean, the natural sequence of things in life is that our previous generation is going to die before us. That's the natural sequence because they're aging before we're aging, okay? And so again, normally burying our grandparents or burying our parents is not necessarily a happy occasion, even with a belief in afterlife. So there's suffering right there. What do we do with it? Basically, we have a couple of alternatives. We either deny it or we get frustrated by it and try to get rid of it by all means, which may not happen, or we accept it and put it in the context of value, redemptive value. And not only for ourselves, it can be redemptive value for others, like an example of tolerance and so forth for others who may be passing through a similar situation. That's also very good here in the States. There are these support groups, you know, people who have survived cancer, people who have some kind of chronic illness. There are typically support groups that help each other out because there's strength, not only strength, but there's comfort in numbers, right? In knowing that other people are undergoing similar struggles, but they're making it through. So if they are, why can't I do the same? There is a document, in fact, which from the Vatican that is called Declaration on Euthanasia, very straightforward. And it came out as way back in the 1980s, because that's precisely the time when euthanasia was coming out, all right, into society and being discussed. It's been 40 years now, but this document is still very relevant. There's a link to it right here. It's not a long document. It's one of these booklets, and you can download it in whatever language you wish. But it does, there is a section there that is devoted precisely to the redemptive value of suffering, when suffering comes, and to help us deal with it. Okay, so that's more on the spiritual side of things. Let me move forward here. Now I want to make the distinction between these two, because as I mentioned earlier, euthanasia straight up is still illegal in the United States. I've also mentioned a number of countries in Europe is euthanasia is already legal, but not here. Whereas physician-assisted suicide is legal in an increasing number of states, not the whole US, but in an increasing number of states. You'll see more than 20% of the states in the US have already legalized some sort of physician-assisted suicide. So what's the difference? All right. In euthanasia, there is typically the healthcare professional is killing the patient. All right. Again, by active or by omission. Say, for example, a lethal dosage, a lethal injection of killing the patient, or by denying a basic care like nutrition and hydration, which is a classical one, when a patient may indeed benefit from that, or when the digestive tract is still functioning. So that's active euthanasia or euthanasia, when someone else is killing the patient. Whereas physician-assisted suicide, okay, so the noun is suicide, and physician-assisted is the adjective, right? It's the qualifier. This is a suicide, so it's the patient killing herself or himself. But because the patient cannot self-prescribe the lethal dosage, the patient needs the healthcare professional, typically the physician, the doctor, to prescribe the lethal dosage. Follow? Because the patient, typically the typical patient is not necessarily a doctor and cannot self-prescribe. Which, by the way, this gets me into talking about 3 key words in healthcare. It's important that we're all on the same page on these key words. So there is prescribing, dispensing, and administering, all right? And those 3 you should know well if you want to be in the healthcare sector. So 3 different professionals that require 3 different degrees to each one of those. Prescribe, dispense, and administer. All right, so if you think about it a little bit, they make sense. So who prescribes? MD or DO? Or even there's a third one who can actually prescribe. It's a particular type of nurse. Is a nurse practitioner. So it's a PhD equivalent. All right, so a nurse practitioner can also prescribe. All right, so those are the 3 who can prescribe. Then who dispenses the prescription? The pharmacist, exactly, which is a D-Pharm, different degree, terminal degree. And who administers? The nurse, okay? The nurse administers. And so you see, who is actually bedside? The nurse. Could be male, female nurse, but the one who's at bedside is the nurse. The doctor is somewhat removed from the patient in the sense that the doctor will review the chart and may do a physical exam on the patient, all right? the doctor will prescribe and walk away. Who has the responsibility to make sure that the patient takes the pill or the medication? The nurse. So the nurse is more directly engaged there, and therefore PAS affects more the nursing profession than the other two, because the doctor can always say, well, yeah, I prescribed the lethal dosage, but they didn't have to take it. You know, they could have left it at the table. And the pharmacist can make the same claim. Yes, I dispensed this because it came from a prescription from a bona fide doctor, but the patient doesn't have to take it. But the nurse is in charge of making sure that the patient takes the medication. They have to document that. So they're caught between a rock and a hard place when it comes to PAS, all right? So that's the acronym. And then we get into the euphemisms. Again, because no one likes to hear about suicide, you know? And in fact, straight up suicide without a prefix, without an adjective, is still illegal in the United States and in many other countries too, straight up suicide. The problem with the illegality of suicide is, how do you punish the offender? If they succeed, the offender is now dead. Okay, now, if they don't succeed, and that's what we call an attempted suicide, then there's intervention. And they can be, I don't know if it's actually called Baker Act. I know Baker Act typically is for alcohol, right? But they can be restrained without their consent if they're showing even suicidal ideation. So suicide is taken very seriously today. And it's not played down, because we have seen in the past that by playing down, because everybody's ashamed and don't want to talk about it, some people actually follow through, okay? So typically they say if, and I say this also because you people are also among other young people, and sometimes there's talk out there, all right? And you have to be very careful. If the person who is talking about considering suicide, and they say typically if they have a plan on how to execute, that should be a big, huge red flag. You got to report that, all right? Got to let someone know, typically in the health profession, because then they've already thought it through, even the means of how to do it. So it gets very serious. Please.
Concerning the illegality part, when you say punish, we're not talking about like being incarcerated or anything of that nature.
Yes and no.
That seems like an
inappropriate
response.
Right. Okay. Well, let's follow through for a moment. Good question. So think about this. If it's illegal, then doing it is a crime, right? And for a crime, there's a punishment. I'm talking law here. And so the typical punishment is some kind of restraint. Now, obviously, what qualifies here, what is the kind of restraint for an attempted suicide person is in a psychiatric ward. Now, is that a jail? Is that a prison? Is that incarcerating? Yes and no. They cannot leave out of their own volition until they meet certain criteria, right? But it is for the good. But so is the other criminal who's in jail, who's in prison, is for their good too. It's also for our good, okay? But but you're right. In other words, if it's suicidal ideation, then that needs to be treated with a competent professional who is psychologist/psychiatrist, and there may be some other MDs involved in it. But
yeah, but one involves like actual therapy, and the other one carries with it a whole world of additional problems.
yes, it's true. They both have, then at the social level, they both have certain stigmas with them, unfortunately, social stigmas. I'm thinking that the person who is just in a straight up prison coming out, an ex-inmate has more difficulty finding a job, for example, but because those are public records. But it is restraining the person one way or another, even if they're an adult.
I just find it strange that punishment is the term that's used for.
Well, no, I'm using punishment, maybe it's a misnomer, I don't know, but I'm using punishment in the legal sense that if for every crime, there's a punishment. Yes, yes, consequence, but legal consequence, you know, of restraining their will, restraining their movements and so forth, at least temporarily. All right. Right. Okay, so you notice that the distinction is a technical distinction, but the end result is ultimately the same, which is causing the death of the patient, whether the patient actually kills himself or herself directly, or it's the medical professional. At least, thanks be to God, to this day, euthanasia as such is not legal in the United States, okay? But PAS is becoming legal. In other words, now the physician has been rounded up into the death killing process. And this is kind of going full circle from where the physicians started before the Hippocratic Oath, which goes back Hippocrates 3 or 4 centuries before Christ, again in classical Greece. Oops. Oh. We know that in classical Greece, they had already developed some degree of medicine, and that's where we get the Hippocratic Oath, right? From Hippocrates. I'm just trying to find the times. Oh yeah, look at that. 5th to 4th century before Christ. And why was Hippocrates and his oath so popular, even for millennia, up until at least last century? Today, the Hippocratic Oath is not used anymore in most medical schools, at least the public school. Some private medical schools may still have it, all right? But I can tell you what has happened there ideologically. However, the Hippocratic Oath is basically focused on the first principle of medicine, which is what? First, do no harm. Primum non nocere is what they would say. Primum non nocere, that's in the Latin translation, okay? But first, do no harm. And therefore, killing a patient is harming the patient, and it's not seen as something positive. So the concern of Hippocrates was that the medical profession, all right, that the healers, that the physicians would not be seen as participating in killing patients because the role was ambiguous. And we know that before then, the physician would also kill certain people, typically contracted by the state. When the state had to dole out lethal punishment, the death penalty, they would engage a physician to try to do it the most benevolent way, the most merciful way, all right? Because the physician would be the expert on killing a person in the most humane way. Humane is the word I was looking for. And what is the classical substance that was used? Hemlock, the hemlock. No, you hadn't heard about hemlock? Okay, so hemlock comes from a plant, and it's an abstract, it's an extract, and that's in fact what Socrates took to kill himself. Remember, Socrates was framed by the state because, according to the state, he was corrupting the mind of the youth because he was challenging them to think and to be creative and to go beyond the establishment, right? And so, and the Socratic method of questioning, you've heard about the Socratic method. The Socratic method is questioning. So you ask me a question and I respond with another question and going back and forth like that. We're searching for the truth, all right? But that was Socrates' big thing. But the state considered back then, at that time in Athens, that he was perverting the youth by these ideas, these creative ideas. And so the youth were using those ideas to challenge authority. Some things never change, right? So youth challenging authority. Talk about a permanent theme. At any state, Socrates was giving, once he was found guilty, he was given the option to either be killed by the state, by a physician, to be administered the lethal dosage, or he was granted the option to take the lethal dosage himself, all right? And so he considered that that was a more dignified way because he didn't want to engage anyone else in killing him, right? So he didn't want that on the conscience of the other person. And so he took the dosage himself. He had no way out. He had to kill himself because the state had already ordered that. And therefore, he took the dosage, and it was hemlock, the poison, okay? That's important because I'm going to talk about the Hemlock Society.
Sorry
please.
questions, but,
Yeah.
What's your ethical view on that rationalization of his?
Frankly, I don't know. I haven't thought it through fully, but it's historical. It goes back to that time. We'd have to consider what was at stake at the time and the culture of the time. You know, another thing about classical Greece, whereas we have inherited a lot from classical Greece. Essentially, we say that Western culture, the birthplace of Western culture was in classical Greece, okay? Not the agriculture, because that went back to Mesopotamia several thousand years prior, but the culture itself, derivatives. So take Latin. Latin is a derivative of Greek, and the Romance language is a derivative of Latin. And we get from classical Greek, what do we get? Physics, astronomy, mathematics, the arts, the humanities, theater, the sciences, all over the place. And so very rich culture. Even the mythology, the Greek mythology, I don't know if you know anything about Greek mythology, but a little bit is that it's very rich. Remember I did the prosopon thing, right? So Greek mythology was very rich, but totally passionate. Bottom line, what I'm trying to say is there was no true belief in an afterlife as such. Not that we have a very elaborate belief in an afterlife in the Judeo-Christian tradition, okay? And so that did not exist at the time. So in that context, you know, perhaps it was justified for him. And also, I think that principle ethics, still thinking out loud here, is that allows us to pass a judgment on the behavior, on the action, but not on the conscience. So my bottom line to your question would be, my answer would be, his suicide objectively was wrong, but I'm not going to judge his conscience. I'm not going to judge Socrates for killing himself. You know, God only judges, and God is the master of our consciences. But objectively speaking, I would have said to Socrates, don't do it. If the state wants to kill you, let the state do it. In other words, let it be on their conscience, but not let it be on your conscience. That's what I would have told him. Okay. So you see, we can do an objective morality. And by the way, I'm going to cover those principles in a further lecture on the distinction between the behavior and the person themselves. All right. And that allows us to do what I'm terming as an objective ethics or objective morality. All right, so the thing about Hippocrates is he did not want the physician to be engaged in killing patients, all right? Because the physician should only be about healing. And then there is the perception also. Keep in mind that the doctor-patient relationship is a very, very delicate relationship. And the foundation of that relationship is what? Trust. I mean, you're going to go to a doctor you don't trust, walk away. The doctor may be a genius, may be the greatest doctor, but if you don't trust that doctor, walk away. It's not going to work. Because you're going to be second guessing, is this really going to be a good treatment for me? You know, so the basis of a doctor-patient relationship is trust. And the trust is mutual. Confidentiality. You also trust that the doctor is going to keep your stuff confidential. You know, they always ask about the social history. What do they mean by the social history? Well, it could be we're sexually active with several partners. That's part of our social history. Okay? You know, so there are confidential things, and we need to trust the doctor. The doctor needs to trust that we're saying the truth, Because we can lie through our teeth. He doesn't know. She doesn't know. They cannot get into our brain. But depending on what we tell the doctor, then they're going to try to diagnose us. Okay, so you see, trust is fundamental, and that's what Hippocrates wanted to make sure that the people would trust the physician and not associate with, oh, maybe this physician is trying to kill me with this medication, right? Because they don't know. So you see the issues there. Okay, now let me get into so the first, the original, let's say, what are these called, acronyms, is PAS, Physician-Assisted Suicide, all right? But also the acronyms have a connotation. You know what I mean by a connotation is they, notice that the words have a particular meaning by themselves. Okay, if we put a second S here, pass along, you know, we're passing him along from this life to the other life. Okay, so there's that background connotation on these acronyms, which are also significant. So the big thing was to try to replace the word suicide because it's poignant, all right? And it's kind of too direct. It's similar to, no, it's not an abortion, it's a termination of pregnancy. Okay, so how about physician-assisted death? It is a death, isn't it? The patient is dying, we're not passing judgment. Okay, so the acronym comes out to PAD, just kind of patting them in the back to go forward. But that one, now they're trying to get rid also of the physician-assisted part. In other words, if we don't want to make it too known that the medical profession is directly involved in this by prescription, by medication that is regulated, all right? And so how about aid in dying? And it comes out to be aid. I'm aiding the patient. So now we're now flipping it into a positive so that the acronym may have a positive spin, a positive spin. But the action itself is the same. Dying by lethal dosage, okay? Or killing myself by the lethal dosage that is regulated, that it's not over-the-counter stuff. So aid in dying. Okay, so the medical profession is involved in it. How about medical aid in dying or physician aid in dying? Made or paid? Because we're going to pay the doctor for that prescription anyway, or somebody's going to pay. All right, but you see how the acronyms have been flowing? And just in case you have your qualms about this, when we look at the document from the American Nursing Association, you'll see these terms coming up, okay? All right, so I think you can tell at this point from my manner of speaking that from a principle perspective, from principle ethics perspective, that is not ethical. Even though it may be legal, definitely not ethical. Okay, I've mentioned before, there are other cases of stuff that is legal and not ethical. Like, for example, lying outside of court, outside of perjury, or adultery. So, healthy alternatives. I always want to present health alternative because we don't want to leave people, oh, you're suffering and you're dying and you're in pain. Well, too bad. Sorry about that. Sorry for you. I'll say a prayer for you, but no, we don't abandon the patient ever. And thanks be to God, there are these two alternatives, which is hospice and palliative care. What they have in common is that they shift. When there's no more cure, they will shift to care. All right, compassionate care, comfort care is the term, comfort care. Because medicine can still do a lot to maintain the dying patient comfortable as possible. So these are the healthy alternatives, and let's look at them for a moment, the similarity and the difference. Similarity is that they are focusing on patient care. In other words, there's no more cure, right? Because medicine has its limits, but there's always care. Care always obligates, because these are fundamental things for life, which, by the way, did we cover care before? I think we covered care in a previous lecture, no? Things like nutrition, hydration, shelter, and human comfort or human interaction. Did we talk about those four? No? Oh, goodness, sorry. Okay. That was part of another presentation or another slide, but let me introduce that now because we can distill care, basic care, all right, or comfort care down to four things. If you can think about them for a moment, minimal care for staying alive, for just like surviving, all right? What do we need? Food, water, shelter, and human interaction. So the first three are more physical, and the fourth one is more psychological / spiritual, but because we're substantially body and soul one, we really need all right? So consider food, we're calling nutrition, water, hydration, minimal for life, shelter also so that we're not exposed to the elements, especially if we're ill. We're not just on a bed outside somewhere like we saw in the middle of COVID when overwhelmed hospitals where they were putting hospital beds out on the sidewalk because they had no more room literally inside. You know, that's a horrendous situation. That's why it's extremely dangerous when hospitals start getting overwhelmed and saturated. All right, so nutrition, hydration, shelter, and then human interaction. We have a basic, natural, fundamental human right to interact with other people, even if we're unconscious, all right? We should have people around us, even if those other people have to be fully gowned. If they're fully gowned, it's all right. At least we know, or we may know that there's someone there, another human being. And that's what I'm calling human interaction. A person should never be deprived of that. So we can consider people in isolation, but that isolation is not solitary confinement. Okay, where the person truly is without human contact, that is actually illegal in many countries to exert that kind of punishment. Exactly, there you go. All right, so that's the type of care, that's the type of care that we're talking about here, all right? Nutrition, hydration, shelter, and human interaction. And of course, a big part of that is if the dying patient is going to be at home, surrounded by the loved ones, okay? I think I mentioned the case of this friend of mine who was dying from bone marrow cancer, and he was trying to get out of the hospital to be at home because of all the restrictions he had in the hospital. It was difficult to see him actually, going through all kinds of protocols. Well, he finally was able to go home. I think we left the conversation maybe a week ago or so. He was able to go home for a few days. I think it was only 2 or 3 days. And the poor fellow, he's because bone marrow cancer, not producing RBCs, not producing platelets, bleeding internally. So he had to go back into he was so anemic, he had to go back in for another transfusion. And while he was at the hospital, he ended up dying, you know, so he wasn't able to die at home, but at least he was at home for a couple of days and ended up dying back in the hospital again. So I don't know what happened there because I didn't have a chance to see him once he was at home. I saw him at the hospital. But that last transfusion, maybe they shouldn't have called 911. I don't know. It's a very tough judgment call when the wife sees that the person is anemic and barely cannot get out of bed. Maybe she got a little hasty and called 911, and so ambulance came. He goes right to the nearest hospital, which was just where he was at Baptist Maine. Okay. All right, so let's look a little bit at some differences with regards to the place. Precisely what I find good about hospice is that they will provide that comfort care at home, including the analgesics and the palliative and the painkillers, right? So they will actually give the caretaker, who is the next of kin, typically, let's say a spouse or adult children or something like that, they will give them morphine by dosage to be allotted out to the patient. Whereas palliative care typically is in the hospital setting. The timing standard is 6 months for hospice, but there's no specified time for palliative care, in part because the patient is in a hospital. And so there are more emergency or critical care that can be given in a hospital, including, for example, a transfusion, and therefore it doesn't really have that 6-month standard that hospice has. Payment. The challenge with hospice is that it's not covered by our insurance. Medicare does, for at least for the elderly, it's picked up by Medicare. Whereas in the palliative care, it goes through the hospital billing. Okay, so typically more insurances cover palliative care. And finally, the treatment is a little different again. At home, of course, it's a little more restrictive. So it's focusing mostly on comfort care and few medications. If anything, it's the type of medication that is not very involved, because again, the idea is that there's no more cure, right? There's no more cure. Now, there could be a comorbidity. The person may be dying from terminal cancer, metastasized cancer, but they may also have pneumonia. And with pneumonia, antibiotics are indicated. So the patient may be taking antibiotics for the comorbidity. You understand, comorbidity is some other illness that is not the main issue, but the patient is dying of terminal cancer. Whereas palliative care, because it is done in the hospital, there may be some therapies or medications that are indicated and that can be done. Again, example, for example, a transfusion. He couldn't have a transfusion at home, so he had to be rushed back to the hospital. Right. So there's plus and minus of for each one. Together, they are a healthy alternative to PAS, but it depends on what? It depends on each patient, right? Whether for one patient, hospice may be more indicated than for another patient, maybe palliative care is more indicated. Let's say, for example, a person who has really no one at home. Okay, they've been living alone up until now. They may or may not have relatives, but if they do, the relatives are far away and cannot come, etc. So then that patient is better off in an institution, right? Because there's no one to care for him at home. Even though, thinking about that a little bit, I think that hospice also has 24-hour nursing now. They go by tiers or steps, because obviously it will cost hospice more to have a round-the-clock nurse or a nurse assistant, right, caring for the patient, than have the family members, and then just the nurse's aide is a support for the family member who's caring for the patient. All right, so it may be a billing thing. All right. Again, the point on these two is that there's a healthy alternative to PAS. Now, terminal sedation. You run across this one, terminal sedation, sometimes known as palliative sedation. The word palliative means what? That there's really no cure, okay? There's no cure, so it's a reference to, again, keeping the patient comfortable. So palliating or keeping the patient comfortable. So it's trying to relieve the stress on a terminally ill patient. And we're talking imminent death, not even weeks. We're talking about days at most. Typically it's hours, all right? So death is imminent for these patients, but they're not yet dead, okay? And sometimes the death process is still lingering. What do we do with the patient? Well, there are a couple of things that can be done, either subcutaneous or IV intervention. And even if they cannot find a line, they cannot establish a line. Establishing a line is essentially putting a needle in through a vein that is thick enough to take at least a small needle, whereby they can hydrate the patient so the patient doesn't dehydrate to death, all right? They cannot even find, because the veins are very feeble. When does that happen? With old age. And when they put, the veins collapse because the patient is very feeble, okay? Old age, that's the challenge. Then, as a last resort, they can even try to hydrate rectally through the colon, because the colon, the large intestine absorbs water. So it's a type of enema that is done. And so try to hydrate the patient through the colon, all right? All right, certainly it's a last resort. The patient typically is in intractable pain. In other words, no amount of medication, the patient has become tolerant to an increase in dosage of the medication. And if they give him more medication, the medication is actually going to kill the patient. It's going to be an overdose. That's the challenge, an overdoses, right? So try not to slip into euthanasia, which is illegal. Then they try to do this palliative sedation. I can also tell you that whereas technically euthanasia is illegal, in practice, unfortunately, it's going on. And it goes on, what is a typical setting where euthanasia is going on? Not jail. Jail is actually more regulated, okay, because there are more eyes looking at that. There are agencies that are supervising in nursing homes, especially like county nursing homes, or they fall through the cracks and the inspector only comes around every so often, but the nurse on the floor or the nurse assistant, especially overnight, may not be the most professional or the most dedicated nurse, or the nurse assistant, right? And they have 30, 40 patients to look after anyway. So, oh no, the patient just died at night. But the patient was actually administered an overdose, you know, or it could be by neglect. The patient did not get the medication that they needed. So in practice, it is happening, sadly, it is happening, right? But the fact that it's happening doesn't mean that, you know, we have to accept it. Just like drug addiction is happening, doesn't mean that we have to accept drug use, okay? All right, finally, a couple of technical words also here between analgesic and sedative, because sometimes people are not very clear. The analgesic is a pain relief, but the sedative is the one that renders a person unconscious. Now, sometimes analgesics also do that, but it's a side effect. It's not the main purpose of the analgesic. The analgesic is trying to target pain relief, but they're dealing with the brain anyway, all right, and neuronal connections. And so at some point, the dosage, again, the higher dosage of analgesic may actually sedate the patient into unconsciousness. And the typical analgesics are opioids. You've heard about the opioid crisis in the United States. It's an increasing use of them, and they are addictive, and that's one of the problems. So addictive means that the same patient with the same illness and the same pain will require an increase in dosage over time by using the same medication, all right, the same workflow. And the typical one is morphine, but some people are actually allergic to morphine. So then there are analogs of morphine that are not as addictive and not as allergic. All right, so sedative is to sedate the person, to put them to sleep, and there are different types of compounds. Benzodiazepines. All right, some popular names there, common names. Okay, let's back out for a moment and review once again, killing versus allowing to die, because some people will say, well, at the end of the day, you're doing the same thing. We just give him medication until the patient dies. Yes, but the focus is on managing the pain and trying to, like we say, kill the pain, not kill the patient, all right? And it does come down to dosage. And that's what is called titration. Titration is drop by drop. And you may see those drips when you go to a hospital on what is known as the Christmas tree. In other words, this little metal tube that has all the liquids hanging from it, right? The saline and antibiotics and whatever is being given to the patient. The morphine little bag is also there in liquid form. And then underneath is a machine that regulates the amount of drip that goes into the patient. And you can actually literally see the drop falling, and that's what they regulate, all right? So it can be faster or slower, depending on a number of things, beginning with biomass of the patient, and then also how the patient is reacting to the painkiller. So I cannot emphasize enough, it's about managing the pain, not killing the patient. Right? As a secondary, as a side effect, the patient may, we're killing neurons one way or another. So if enough neurons are killed, eventually the patient may go unconscious. And so as a side effect, we are shortening the life of that patient. But it's not the intention, it's not the intention, and that's crucial. All right, let me see, we got about 15 minutes. Questions before we look at a couple of cases and in the United States, how this movement came about of legalizing PAS. All right, it starts with the Hemlock Society. Again, back in the 1980s, you see the document on euthanasia, because that was the big topic in the 80s. And it was known as the Hemlock Society, picking up the name from the poison that Socrates took, which was a popular poison at the time. Cicuta was known in Latin or Spanish, maybe in Greek also, cicuta. All right, so this movement started in the 80s, and it was founded by four persons, a couple, married couple, and then two others, the Humphreys, and then Jerry Laurie and Faye Gersh. They started this movement in California back in the 80s, and they were advocating for a right to die and assisted suicide. All right, but the right to die, you see the point here, right to die. We all have a right to die, right? We have a natural right to die, because what's the opposite? That we don't have a right to die? Can someone prevent us from dying? If we're dying, should we be prevented from dying? Sooner or later, we're gonna die, all right? So the way the language is used, the connotation and denotation of the words, very important. We all have a natural right to die, but they weren't really advocating for that. They were advocating for a right to kill themselves. And that's why the suicide. This is more honest, okay? Assisted suicide, because they couldn't do it themselves, okay? They didn't want it to be gory and bloody with a gunshot or hanging or anything drastic like that. They wanted to go in peace, right? So good life, good death was their motto. Good life, good death. Not messy, like blowing your brains out or something disgusting like that. All right, so they advocated for this. Obviously, they have very different value system that, let's say, Judeo-Christian tradition was, but they have a right to have their own values, right? So they moved to Oregon at the end of the 80s, and that's where it took root, because by the 90s, they actually got Oregon to legalize PAS. And that was the first state to legalize PAS in the 1990s. We'll see it. All right, to follow the discourse, what happened was, at some point, they partnered. These two fellows, Humphrey and Faye Gersh, wrote a very famous book. The book is called Final Exits. All right, so you go online, you can look it up, Final Exit. And so they formed this network to try to go national. They had already legalized it in Oregon. They had a success to tell about. And so they started this network to promote this at the national level. And finally, there was another society out there called Compassion in Dying, and they merged Hemlock Society with, or Final Network, merged with Compassion in Dying, and they were looking for key phrases that would give the positive spin to physician-assisted suicide. And the positive spin was two key words that are very, very dear to the American culture, the American ethos. All right, one is compassion and the other one is choice. We want to be known as compassionate people. Who doesn't want to be known as a compassionate person, right? And of course, we're into the land of choice. You go into the supermarket, you want cereal, how about 57 brands? Ketchup, 35 brands, all right? So we're into choice. And therefore, these are the two key words, compassion and choice. Compassion and choice is now the current movement, the current version of the Hemlock Society that is intent on legalizing physician-assisted suicide in every state of the union. But unlike Roe versus Wade, that took the case all the way to the Supreme Court and got the Supreme Court to legislate at the federal level, legalizing abortion throughout the whole 50 states. Unlike that, they realized that this would be a higher hill to climb, a steeper hill, so they're going state by state, because then they only have to deal with that state legislation, all right, as opposed to the whole country. So they have been making a lot of headway state by state. And one who was a crucial figure early on was Dr. Kevorkian. Any of you heard that name, Kevorkian, Jack Kevorkian? Okay, so here's Jacob Kevorkian. He was an MD, he was a pathologist. And what does a pathologist do? They examine the cause of death. They examine cadavers and they examine cause of death, all right? So he was very familiar with death, and he was convinced that people had a right to kill themselves if they wanted to. So that was his philosophy, and he actually acted on it when it was still illegal. And so in the 80s, he was very well known for killing patients, and he was tried for killing at least 130 patients by assisted suicide, okay? In other words, he prescribed the lethal dosage. And at that time, he invented a machine, all right, which was known as the death machine or the killing machine or the Kevorkian machine. And he even put the compression online so that people could build it in their homes on their own. And it basically, but it has two, it's a double dosage. It's a two dosage thing. One dosage is a sedative. So it puts the person to sleep, only to sleep, all right? And the second dosage is actually an overdose of potassium chloride. And what does a high concentration of potassium chloride do? Accelerates heartbeat to the hilt. And so heart attack, cardiac arrest, okay? Overdose of potassium chloride. Stay away from it. So that was the Kevorkian machine, all right? And here is himself holding one of the needles. Yes, the needles had to be inserted, so that's the physician assistance there. But the patient themselves are pulling the levers. Okay, so the first lever would be the sedative, and while the sedative is putting the person to sleep, then pull the other lever so that the potassium chloride will come in afterwards. He was sentenced to 10 to 25 years. He served 8 years in prison. I guess he got good behavior and was out on the condition that he would not promote PES anymore or stay away from it altogether, but he continued and was not reincarcerated, all right? Eventually, he died of liver cancer. But he died in his 80s. Now, his cases were examined, and most of his patients did not have a terminal illness. Some had some chronic illness. Others were hypochondriac. What does hypochondriac mean? Yeah, you're always worried about having some kind of illness, and you're afraid of doctors and medications, hypochondriac, and you want to be medicated all the time because you think that you have some kind of illness, all right, and something's wrong, but I can't tell what it is. Some were just depressed, and he was killing people who are depressed, all right? That's not the proper treatment. He wasn't even a psychologist or a psychiatrist. So sadly, he gave a lot of impetus to the PAS movement because he was an MD and he risked his career, you know, to live out of his convictions of the philosophy that he thought that people did really have a right to kill themselves. So along those lines, now comes Brittany Maynard. You ever heard this name? This is in the 2000s, okay? Okay, so Brittany was born in the 80s. She married in her 20s to Daniel Diaz, lived in California. Didn't have any children, but they did have a dog that they were very fond of and walked the dog in the woods often and so forth. So they had a very outgoing life, nature and so forth. Brittany Maynard, yeah. 2 years into the marriage, she gets brain cancer. And it's a very aggressive type of brain cancer. And it's moving fast, quickly escalates to stage 4, which is terminal. And this type of gliocytoma is very aggressive, and it affects the brain pretty drastically. Beyond the headaches, it also includes seizures, memory loss, physical weakness, muscle tone, muscle control, visual impairment, language, cognitive decline, personality changes. It goes on and on because it's affecting the cortex and conscious activity and so forth. So it's very, very debilitating, fast moving, and painful. So she didn't, she went through some early treatment early on, a sectioning of the brain, a resectioning that they call resection, partial resectioning, which is cutting out a part of the brain where the tumor is. But unfortunately, the tumor had spread already. All you need is a few cells, one cell, to go elsewhere and start growing again, right? So that was just temporary, really. At stage 4, there was no cure any longer. So now she's terminal. But in California, PAS is not legal, was not legal back then in the early 2000s, all right? But in Oregon it is, and you know the West Coast has only 3 states, and California, Oregon, and then the third state up is the state of Washington. So they're neighboring states, and of course, what happens, Compassionate Choices picks her up on the radar and makes a sweet proposition to her that if she becomes, you know, the poster child for them. Because how incompassionate are we going to be? This young lady is dying from a brain tumor and you're denying her to have a good death, a peaceful death, Yes, with an overdose. It's a combination of pills now. They do the same thing, the pills, the lethal dosage is the same, similar, but in solid form instead of liquid. In other words, you take first a sedative, well, you take both together, but the sedative acts faster and puts the person to sleep. And then once they're asleep, then the potassium chloride does its thing on the heart, okay? But the person is already asleep. So they moved to Oregon. Daniel, the husband, said, honey, whatever you like, it's your decision, so I support you either way. And she says, no, I don't want the cancer to beat me. I want to beat the cancer. That was her mentality, if you think about it. I don't want the cancer to beat me. I don't want the cancer to kill me. I want to kill the cancer. All right? All right. It's only that because it's terminal cancer and there's no more cure, killing the cancer means killing the patient. The only way I'm going to kill the cancer is to kill myself. All right? Because the cancer is going to progress inexorably. So they moved to Oregon for PAS. What's the challenge? Well, the challenge is that in Oregon, PAS is only legal for Oregonians because the state of Oregon doesn't really want all of the people who want to kill themselves to come into Oregon and kill themselves. All right, they have to be Oregonians. That's a law, it's a state law. So they don't want to be attracting people from other states to be killing themselves there. They have to be residents. What's the time frame for becoming a resident? To live in the state for 6 months. So she actually had to live for 6 months with the brain cancer to qualify for having PAS, all right? And so it was all set up beforehand, and the day after that she became an Oregon resident, she got the lethal dosage prescription, and that night, the two of them went to bed, and she took the dosage, and she died overnight. All right? So, right, right. Correct. Follow through all the way. Right. Now, you get that? Right. Okay. So this is her words. You can look up in greater detail, but her words were she didn't want the cancer to beat her. She wanted to beat the cancer, but there was no more cure because it was terminal stage 4, so there was no more medicine to cure that cancer. Let's analyze that a little bit from a principle perspective where we don't pass judgment on her conscience. Never, ever. But the behavior, so what was the behavior? Physically, a behavior is something that we do, right? Or that we fail to do. For example, we don't get out of bed in the morning, that's a behavior. We stay in bed is the behavior, right? But what was her specific behavior that killed her? Come on, she did 2 things. She took a lethal dosage and what did she do with, how did she go up and down? With some water, or even tomato juice, I don't know, I think it was water. But that was an actual physical behavior, right? She had to do that. Daniel didn't put it down her throat, no one else forced her, the state didn't force her. She literally reached into that night, what is it called? The nightstand, and took the lethal dosage, ingested it, and swallowed it with some water, put the glass down, and went to sleep. So that was her behavior. And that behavior was what kind of behavior? It was suicidal because she was knowingly taking a lethal dosage. All right, so the behavior was suicidal. Did she kill the cancer? No, the cancer was still in the brain. The cancer was still in the brain.
It depends. She didn't really kill the cancer as a collection of cells.
No, she killed herself. She killed herself.
I think she understood the concept of what she was doing. It's just that she was operating under a different framework.
Absolutely. But my point is this. Did she really understand what she was doing, or did she just want to kill that cancer, even if there was no cure for the cancer? Let's say I want to fly. Well, I can use an airplane, a helicopter, or a giant kite, or a parachute. But I don't want to use any instrument, but I still want to fly. Well, I can fly for a little bit, but it's going to be a downfall with acceleration.
I think if it was something that was done in the spur of the moment, we could wonder about whether she really understood it. But when it's something that's done over the course of several months of pre-planning, I think she very much understood what she was doing.
She did, but there's also something called fixation, where people just don't come out of a behavior, and they're locked into it, you know, and they have made a decision, and now, keep in mind, she has become a public figure. She has become a poster child, and months, and this was in the news in the month. That's why I asked you about both, because these people, while it was happening, was all over the news. Not only the US, it was in the BBC, it was in the world news, all right, periodically. And it will come back to you. And once you see some more, if you want, online, you will see it will come back to you. You know, so now it's like committed, right? All these people have this expectation about her. How can you not follow through? So would you say that perhaps there was some social pressure on her to follow through?
Perhaps, only she knows.
Exactly, only she knows, right? And that's why we cannot get into her conscience. But I can say without a doubt that her behavior was suicidal behavior, objectively speaking.
Yeah, it was suicide.
You see? Now, what do you think is in the cause of death of the state of Oregon death certificate? What was the cause of death? Before we go there, what was the cause of death?
Suicide.
Lethal dosage. Lethal dosage, you know, heart attack or overdose of potassium chloride. All right, that was the cause of death. Was listed in the official death certificate record of the state of Oregon is brain tumor, terminal brain tumor. But the brain tumor was still going on when she died. You know, the brain tumor did not kill the brain.
Is that some kind of lethal?
It is. They say because of death with dignity, because of the dignity of the person. They don't want to put, it's illegal actually to put in Oregon that they committed suicide. It's actually illegal. You see the flip? You see that flip? Because how honest is that? You know, so what vital organ killed, what vital organ failed? We can look at it another way, physiological. Let's just concentrate on the body here, all right? With all due respect as a human being, but some vital organ has to die for a person to die. What vital organ died on Brittany? The brain or the heart? The heart, and the heart was not sick. She was a 30-year-old, all right? The brain was dying, but it wasn't the brain that killed her. It was the heart. So it's another way of looking at it. And the heart was, so the overdose of potassium chloride was no medication for the heart. All right. So objectively, that's why I can say objectively, it was suicidal with all due respect. And I will never, ever pass conscience on her. I know that there was a lot of pressure on her. And the first pressure was the family members and her loved one saying, honey, whatever you decide is fine. You want to jump off the bridge? It's fine. You know, there's a golden gate, the golden gate. Okay, see, so that standoffish position, because we love you, we support you in whatever you want to do. Please, whatever I want to do, really? What if I'm suicidal? Oh no, whatever you want to do. So we have to be careful. The misconception of compassion is not real compassion, you know? So anyway, these are the issues, these are the challenges. But of course, that's what Compassion and Choices wants. Therefore, I know we are very proud of independence and respecting other people's values and other people's decisions and so forth, but frankly, there's still some behavior that is unethical and even illegal in the United States, you know. Even if I want to rob a bank a lot, I should not do that. And I don't have a right to do that. So these are the states now that have legalized PAS, beginning with Oregon in the 1990s. By the way, in California, just to finish that story, in California, it was illegal up until 2014 when she moved to Oregon, right? And it had come up in the ballot as a popular vote because the legislatures didn't want to have that on their, you know, on the record that they passed PAS by legislation. They send it out to popular vote. And time and again, on popular vote, the people of California had voted against PAS, against legalizing PAS. So that's why she had to move to Oregon. Immediately after she died, it came up in the legislation again, in the ballots, again, in the next cycle of balloting for California. And in 2015, what happened? California legalized it. It's like the whole state felt so guilty about Brittany having to leave her state and endure 6 months more of pain and suffering, you know, that then it went through. Okay, so you can see they're relentless and they are very cunning in how Compassion and Choices is going about this. So Oregon was the first one, and guess what? Just a few months ago, New Mexico. Even during COVID, New Mexico got to pass, I think it was April or something like that. It goes into effect this month, in June. But New Mexico is the latest one. These are 11 states, so now we have more than 20%, because 10 out of 50 is 20 out of 100, right? More than 20% of the states, more than 1/5 of the states of the union have already legalized PAS. And this list, in my opinion, is not shrinking anytime soon. Predictably, we can take a safe bet that this list is going to increase. In fact, PAS is in the legislative works at different stages in another dozen states at least, including Florida, all right? So it's in the workings. They continue to pound the shoreline with the wave until that state also capitulates. So that's the state of affairs. It's beyond 3:30 now, so I'm going to leave the document, the ANA document, for next time. I'll pick it up at the beginning of our next lecture, okay? But you can see these are the issues of the time. Again, another challenging, controversial issue. I've tried to walk through all the subtleties involved, but we have to be very clear thinking when we are in bioethics, because it can make it sound as how harsh, how uncompassionate you are. Okay, folks, stay tuned. We'll meet up again on Friday, and I'll post the things as always, all right? Any questions out there in the virtual world? Comments? No?
Nope. Thank you, Doctor, for the enlightening lecture. We'll see you on Friday.
Okay. Thank you. Bye.
All right. Thank you.